Hello and welcome back to the podcast. So today we're going to be talking with Luke Brantley here, who is going to be our next meetup guest in 2 weeks. And we're going to be focusing on AI in the healthcare space. To give Luke a quick introduction, he is a data scientist that works for Cone Health and their AI Center for Excellence. So Luke, how are you doing today?
Doing good. How are you doing?
Doing all right. So what does a data scientist do in, I guess, the healthcare space, and how does AI plug into that?
Absolutely. As a data scientist, my day-to-day is, creating machine learning models, predicting either patient outcomes or more administrative things like trying to understand our demand so that we can staff appropriately. It's a very wide array of things that we work on, from clinical to administrative and financial and things like that. Kind of my secondary duties at Kona, I working to implement some of the AI solutions that we bring in from vendors and third parties, some project management type things there, some ROI analysis, a lot of things that, kind of that dual part of internal development of AI tools, as well as onboarding tools from other companies to help improve, ultimately help improve how we can provide care, either, make our providers, our doctors and APPs lives better, or directly to our patients, how we can improve their experiences.
So, I mean, I've never really worked directly in the healthcare space, but I have some friends that are there. So there's the business of running a hospital, but then there's also kind of the data related to outcomes.
Yeah.
So could you break down some like different, either do you have a different approach for the kind of the two camps, or is there, some different projects that you might be working on?
Yeah. It's all connected, but it is, once you learn more, there's a big spool to unravel. Kind of the quick rundown of current day healthcare. We don't have a podcast big enough for that.
That's true.
Yeah, so you go visit the doctor, the provider's entering details about what's going on. It might order some things for you, and all of that gets documented in what's called electronic health record. And the big one that Cone uses, and I think over 60% of hospitals use, is called Epic.
I've heard of that.
Relevant for future topics. They're doing a lot in the AI space and just have so much influence over the data that we see, because it's how we're inputting our data, and then kind of we use that data once it's input on the AI building and analytical side to say, what some projects that we've done in the past is, looking at a specific use case. So, what are the likelihood that a certain patient, given some characteristics that we can see, what's the likelihood that they're going to end up with a certain disease or a certain outcome, and then also beyond that, just kind of on the administrative side, you're still looking at the same data. It comes from the same place, but a lot of times it takes some of the clinical knowledge of like what types of cases would you see in a specific department, but then, like I said, in the case of staffing, like what's going to get more people into the ED. That's a lot of that is just kind of environmental and not really clinical. So you might see some in seasonality and things like that.
So like you're looking externally of like, oh, hey, we're moving into fall, it's cold season. Right. So that might have an uptick in how many people are coming into, like, when we were talking about, like, the ERs in America right now are crazy.
Yeah, absolutely. And I'd say there's kind of a couple different sides of where AI is commonly seen in healthcare. There is that, I've heard on previous podcasts that there's different definitions of how you want to consider what is AI versus similar terms or
Let's take a sidebar. Like, what is AI? What is the definition of AI to you?
Yeah, to me, I would say the definition is a non-natural system that has a learning mechanism that can be stored and utilized. Okay. And so I try to, whenever I go through the process of delineating where other portions like machine learning or RPA or different solutions within that realm exist or coexist, I find that to be not as useful a discussion, even though I've had it in my head 100 times. But more so, I think it is useful for people to understand. They're trying to understand the AI space a little more, to know that there is that necessity of a learning mechanism, and understanding what a learning mechanism is in a non-natural source.
Okay. That's interesting. So with ChatGPT, what is the learning mechanism there? The language model?
Yeah. And so the process in which it learned to take in text and output some other text that is appropriate or liked by the people viewing it. The goal of it is one of the more complex ones out there. And that learning process occurring over billions of examples and having a learning structure, if we think about it, corollary to the brain, the whole field kind of was inspired by the brain and neuroscience. And so
neural networks, that kind of stuff.
Yeah, exactly. Neural networks. And so having billions of neurons that it's learning to be able to parse complex relationships from what it sees to learn from.
Okay, so back to healthcare. So are you guys using like AI agents like on the healthcare side, or is that more or on the admin side?
Like I was saying, there's the machine learning kind of tabular side of let's look at histories and let's make predictions, things like that. That has been happening for, I'm not at least a decade, probably longer than that. But as far as the application of generative AI, large language models, that type of thing, there's a pretty wide array of where different providers are jumping into it, implementing it. I'll go over kind of some of the more popular uses at this point. One of them is ambient scribes. And so I'll explain what that means.
That sounds really cool. That sounds like a cool band.
Yeah. So that's a good point. So scribe, a lot of doctors historically throughout the years have had scribes, which are people, often like interns, people in their gap year before med school, things like that follow a doctor and pre-write their notes, which are like the summaries of a visit. And it takes some knowledge to be able to translate the interaction with the patient and some of the terminology the doctor might use to make that concise in a way that they will store in the record. There are today still human people, their job is a scribe, and they do that. It's also kind of a nicety. Not everyone has a scribe, and it's often been only for people in kind of the office setting when they do have that. There's a lot of new solutions that are listening to conversations up between a patient and a provider and summarizing them in a way that fits the format and uses the medical terminology to parse out what are the interesting or necessary points.
Like what's the notable?
Right.
What's, wrong or what's curious.
Yeah.
Okay, so does it basically just have like a bank of here's like all the coding for all the different things that could be going wrong? So like in there.
Yeah.
Because I don't fully understand, like the scribe, are they like writing like just shorthand, or are they writing like literal like shapes or?
So
sorry if that's a dumb question.
Not at all. I don't know exactly what historically scribes have generated. It's my understanding is the starting point for a note that you could then see in like your patient record. But yeah, I think at this point they were trained over like a bunch of different historical examples of these conversations. So companies that have actually recorded these conversations and then taken the notes and seen what were the important parts that the provider decided to pick out of that conversation.
And then on the data science side, like if you could store all that in a database, you could potentially like trace, hey, these patterns are happening, and then start, I teach analytics. One of the things that I often teach is like, there are three different phases of analytics. So like 80% of businesses are just looking at historical trends and then trying to make out what's going on in the future. But the example I always point to is a hospital for predictive analytics. Like if you have enough volume of, hey, we're seeing these specific, situations with this specific demographic, like you can start to, get to a point where, hey, we need to proactively start,
right.
We need to get you down 10 pounds because you're at very high risk of a heart attack or something like that. So that's pretty cool.
Yeah, absolutely. So, that's kind of more of the traditional machine learning type side of things, which is generated by that electronic health record
Okay.
data. And so, my team, we've built things that try to predict. So one of the projects I've worked on was trying to predict people that need to go to palliative care, which is like one step up from hospice. It's just a way of, this was specifically for oncology. So having basically a little bit less aggressive treatment plan for cancers, but the kind of status quo of an oncologist is like, no, I want to kill the cancer, I want to beat the cancer. And so they weren't having the other perspective from the patient of like, they also have to worry about their quality of life
Right.
during that treatment phase. And so we tried to pick out, one, what is a patient that needs palliative care? What does that look like? Defining the objective that you want your model to train on, then look at seeing if we can identify people who are going to land in that definition before it occurs. And so armed them with that of like, this is someone who's heading down a path that they're going to have more complications.
So it's
not necessarily,
okay.
Actually. It's kind of a complex definition, but
yeah.
Be able to provide them some treatment options that might ease their journey before they're really suffering from some of the treatment. Some other models that are prevalently used are within a hospital stay detecting sepsis, which clinically, I'm not a clinician at all. I think it's something to do with like,
it's like an infection or something, right?
Yeah, like in your blood, something like that.
Yeah. Like
it's really bad.
You don't want your wound to go septic because
Right.
then it could kill you, I think.
Right. Yeah. And so, looking at some of the biomarkers that are kind of that they've found through machine learning modeling and things like that, try to detect that and then also implement that into the hospital stay process so that gets flagged to the right people that can then take the measures to act upon it before, it causes actual negative outcomes.
Interesting. This is a total sidebar. Did you hear the Theranos lady? Her husband is launching a new healthcare startup.
Yeah.
They're not starting with humans. They're starting with animals. Doing something very similar, but with veterinarians. I don't know. I mean, I guess that's Theranos is very rare. Like it's very rare. Well, first of all, like the scale of that, because when they're like billions of dollars invested into, what I'm talking about with Theranos, right?
Yeah.
Whereas like, she faked the blood test.
Right.
But what I'm kind of curious about with the Theranos thing is like, how did people not get the data behind that? And like, I guess they were fabricating it, right?
Yeah, I don't know the story of kind of what part was fake.
Okay. I watched like a YouTube documentary on it like years ago.
In that vein, but very differently, there is a growing application within healthcare of genetic AI research in which people get DNA tests. Cone is doing a thing where you can go get your DNA tested and you can see what biomarkers you have for certain diseases. But then beyond that, they're using that in a big, huge pool of hopefully, like hundreds of thousands, millions of people's DNA, be able to say, connect that to their clinical records and say, we see people with these specific genetic makeups are more likely to have certain things or develop treatments that work better for certain people, and that based off of their genetic makeup. That's called personalized medicine.
That's really cool. Because like right now, healthcare seems very reactive.
Yeah,
like it's like you get sick and then you go, as opposed to if you could have a baseline of like, hey, here's the a deck of cards that I got. This is the hand that I was dealt. And then you kind of live your life, or at least try to, being mindful of different things that might affect.
Yeah. Another realm that's kind of growing is the analysis and use of wearable data.
Interesting.
Yeah.
Because a lot of people are starting to wear the watches.
Yeah, absolutely.
Yeah.
And both of these fronts are, I would say, in the emerging stage. There are places using it in clinical practice, but it's still research startup early stages. That I saw a study yesterday that there was some project where they found a wearable could detect Parkinson's 2 to 5 years before onset, just off of the the phone's pedometer and seeing that the gait changed and things like that, and that there was a slight buildup to that before the actual diagnosis of Parkinson's occurred. So there's lots of the statistical side of it seems to be proving out how you implement that into healthcare, how you get a healthcare system to act upon those things is the much bigger problem, or not problem, but bigger portion to figure out. It's harder.
Yeah, it's getting adoption and implementation, right?
And not just like people believing it, understanding how you deal with the uncertainty of the output of AI.
Right.
If you start someone on Parkinson's that doesn't end up having Parkinson's, what have you done to that person?
Right. Yeah. That, or even worse, it could be going into a cancer treatment or something that's. Well,
Right.
Actually, I don't know. I mean, is the treatment for Parkinson's pretty kind of hard on your health?
Unfortunately, not a clinician, not really sure.
But I see your point though of you don't want to get a misdiagnosis and then go through something very traumatic or very harmful to your health to fight something that's not even there.
And in general, healthcare organizations, that's kind of the operating status, is that you have to prove that the risk is worth it, and how do you mitigate, how do you deal with that risk? And a lot of that is, we've talked about this before, that a lot of the AI in healthcare is augmenting people. It's keeping the providers in the loop.
Gotcha.
They still have the expertise to kind of gather all of this information. It's more of just another data point is really how it's being used. There's much less of it that is automating AI output to a clinical action.
Yeah, you don't want to get your blood work done and then all of a sudden the AI is like, wait, I've diagnosed you with these 3 things like that.
You take your blood work and you have pills in the mail that
right. Yeah.
Sure, I guess.
That sounds like some wild dystopian future. That's really cool though. So why is innovation within the healthcare space, is it tied to, why is that so tricky? Is it because it's tied to kind of you're dealing with life or death, right?
Exactly.
So they're that's the one big kind of critique that I've heard of the new Doge initiative and the Silicon Valley startup ethos into the government of, Zuckerberg's move fast and break things. Not so smart when you're dealing with, if you break it, then I'm going to die, or my mom's going to die, or my dad. So that it's interesting because I'm not in that. I'm not in the Zuckerberg world, but I'm kind of in the startup space.
Mm-hmm.
So I conceptualize risk a whole lot. I'm definitely less risk averse, I think, than the people that are in the healthcare space. And I'm actually sitting down and thinking about it. That's a really good thing. You don't want to just be fly by night taking all these risks.
Yeah. And I think so. Doctors, they all swear to the Hippocratic Oath, and I don't know it by heart, but a portion of it is first do no harm. And so I think the logical, yes, you're making life or death, or at least quality of life decisions, but even more so, there's that history of we have to. It hasn't been. We're in a shift. We're in a transition period, and these solutions still have to prove that they can be trusted in every environment for every patient. There's especially in healthcare, a decent amount of risk when applying models to diverse populations. So, you mentioned early on the imaging detection, things like that. Although I'm not super deep on kind of where that's at, I think part of the hesitancy of applying it is that a lot of the data sets that generate those models are white Americans.
Okay.
And then when you apply some of these things on darker skin tones, is directly going to impact the model. It's
so just the image is darker.
Right.
Wow.
Right.
Okay.
Well, I mean, the
it's
the
saying
skin and the things
there's something wrong here, and it's no, yeah.
Right. So that's a logical example that makes sense of where the training set directly can affect the performance on a different population. And it's something we've seen too, just with the standard machine learning risk predictors, that if you apply it to a hospital in California, it will act differently than the Greensboro market. Just the people, the way they live, the types of people that live there is different groups. And so, all those things matter in healthcare. So there's a lot of different factors that have to be taken into account, just because it affects the model and therefore leads you to need more proving out of the risk.
Yeah, that makes total sense. So what do you think as far as, I mean, I know this is a shot in the dark, but what does the future of AI in healthcare look like, you think?
I think the future is very pervasive. Like I said, I think we're in a transition period, and that, as a slight tangent, I think in this transition period, we have to do as much good as we can with what we know, and that, it takes some risk averseness, it takes some experimentation, but that I think that, we will get to the point where, and kind of forced to by just the landscape of healthcare, that there's a growing demand of healthcare. There's a diminishing supply of doctors. You're going to have to bridge that gap somehow. Either people aren't going to get seen, or you're going to have to enable that smaller workforce to see more people. And I think that need right there is going to drive adoption of some AI systems to have growing influence over how people receive care. I think the other piece that I see latching on even more, depending on things like regulation, is direct to consumer healthcare AI type solutions.
Well, I have heard of some people using ChatGPT as their therapist.
Yeah.
Which, I don't know. ChatGPT agrees with me all the time, so I'm not so sure that's so smart. But so you think that, maybe 10, 20 years from now, people are just going to be able to type into an AI interface, hey, I have this symptom, what's going on? I mean, because people do that now with Google, and it's always cancer, it seems like. Oh, I'm dying.
Yeah. I mean, there's solutions that are built out now that healthcare systems are using that do pretty much that. The tough thing, once again, the AI system, especially looking at a random human being, is still only going to be able to answer as accurately as the information is provided. So you say, I have, a runny nose, but you don't tell them you also have cancer, they're not going to be able to give you what's your biggest problem to worry about.
Right.
Things like that. And so I think that people are going to care about their health. And so there's going to be, and the touch points for healthcare are very low.
The annual checkup.
You can only do so much with that. And the interventions that healthcare has had traditionally, it's classically called sick care, because you care for them once they're sick. There are organizations like Cone that are moving towards a different model, a different incentive model called value-based care, that is looking at trying to be a little more preemptive and intervene when we know patients have certain problems, make sure that they're acting upon those so that they're staying steady throughout their journey. But more specifically to AI, I think that's where the impact of wearables will be significant for those that have them, but that is a smaller portion of the population. I think that there will be more options, and I don't know if they'll be super regulated. And I don't know. Right now, the culture is to not regulate. And so how much can we
not regulate what? Like the wearable side?
Or AI development.
Oh, I see what you're saying.
Not a little less specifically to healthcare, but if that is the mindset that continues, I could see more things being released to the public, some of that catching on, whether or not it's actually how much your willingness to accept harm given some benefit to other portions of the population. There's kind of the balance being.
I really haven't thought too much about healthcare or AI regulation. It sounds like, have you kind of sat with this or researched this?
A little bit. There's people that are much more in tune with what's going on. More so that, the current mood is hands off, let's see where things happen. At least in the US, you see a very different strategy in the EU, and that there's some complaints there that it's over regulated and that it's reducing the ability to innovate. But when it's applied to healthcare,
you probably want to err on the side of caution.
Or you need to have some, I don't know.
So yeah, that's a tricky one, because if you're on the side of caution, then there's an opportunity cost of if you would have gone faster.
Right.
How do you quantify that?
Yeah.
I mean, you're the data scientist. How do you quantify that? Is it I guess it gets very theoretical very quickly.
Yeah, and I think the bigger thing is that, like I said, it's the scale of how much benefit can you gain to how much harm are you implementing with new tools, that you're making the decision knowing that it has, in statistical speak. I won't do statistical speak. But you know that your model's going to be off sometimes, and that you're accepting that who gets to decide that? Who gets to decide that threshold?
Well, because I guess as far as when the model's wrong, like somebody's dying, but then also too, there's probably a malpractice lawsuit. So it's like you get
that's part of the regulation. Like, who is at fault? Is it the vendor who made the wrong prediction? Is it the provider who said, yeah, let's go with it? Those are a lot. I think that's a lot of stuff to get figured out.
It's interesting because I haven't had this conversation before, but I went to the Chamber of Commerce's like launch event. Like they had businesses like with their pitch deck, and I think the number one voted one got like 10 funding. I ended up sitting next to a IP attorney, and I just asked him like, hey, I'm working on this project where we're using ChatGPT to come up with questions for this practice test. If it is very similar to the SAT, like is that plagiarism? And then he didn't really have like a straight answer. Like right now, it's like if AI creates it, if I'm understanding correctly, I think there's like not really ownership there.
Yeah, I mean, I think there's several lawsuits out there where people are trying to go after them and prove that point.
Like the Studio Ghibli, I don't know if you've ever heard. So Studio Ghibli is like a very famous animation company.
Yeah.
And they have a very distinctive like type of artwork that they've done for their films. And people are now recreating their selfies in that image.
Sure. Yes.
And now I think, but I mean, who do you sue? Because it's kind of like a whack-a-mole. It's like, okay, ChatGPT gets shut down, I'll just go over to Claude, or I'll go over to DeepMind, or like they just pop up.
Yeah, and that's where that regulation piece is, like, who has the right to win those lawsuits?
Interesting. Okay.
To my understanding.
Yeah. Well, it's funny because when I think of regulation, I think of like governments going and like instituting specific laws, but it's almost like there's precedents in AI that have not been set yet.
And the governance of AI and making AI policies is another big thing that healthcare systems they're trying to tackle early, because there is such a risk of getting things wrong, and that you have unique problems such as how to generally train models to handle diverse populations when a patient interaction is with one patient. You want to see your aggregate metrics work well, but if you know that you're treating one population poorly, that's an issue. And that is something that healthcare organizations are on the hook for. But so, it's been interesting being part of some of those conversations. It's still something that everyone's still trying to figure out, setting policies that, once again, aren't too restrictive, but allow you to try to innovate and get more juice out of what the AI world is throwing at us.
Yeah. So I feel like we've had a very high level conversation. Boots on the ground, what does this look like? Are you writing code in Python? Are you using ChatGPT like interfaces, like text, or is it all of it?
Yeah. So I mean, once again, I'll kind of split it into the two parts of internal development and external tool implementation. Internal development, like we have a team of data scientists at Cone that we code in R and Python, and we use machine learning packages that are open source. We do have, I guess one insight is, we do have the ability to use large language models just within our healthcare data. Is sometimes tough to work with because
HIPAA, right?
Yeah, HIPAA. You have to protect personal health information, PHI. And so within the way that our data is structured within Microsoft Azure, they have models that you can call where all of your data stays within your data tenant. And so because of that, we control kind of what that tenant looks like. We're able to
Gotcha.
use some of that information within there. So yeah, we're calling them APIs for certain things. And once again, this is like limited scope. It's a lot of it is, especially on the LLM part, investigative. It's working with clinicians to say, all right, we can extract this insight from clinical notes that's one of the big things is like making clinical notes discrete. And so that you can then do more.
What do you mean by discrete? As in like 1, 2, 3 as in like a discrete value?
Right. So understanding, did someone come into the hospital with an infection that didn't get documented in the normal place that it should within an HR, but it was written down in the note?
Yeah.
Then we can know, was it something we caused or did they come in with it originally? Just kind of that's one example that we're working through. And so, that would be, we're not really making up new information, but we're making it more accessible. And then working to get that into their workflow is the other tricky part that's super necessary.
Why is that tricky?
Providers' time, clinicians' time is so valuable, and so there's very little downtime that you have to get information back into their current workflow, or else it's just not going to be used.
So you're basically like competing with all the other things they're doing.
Right. And so how do you make sure that you're giving them data information that is useful in a way that they're going to see it and be able to act upon it?
So it's the timeliness piece, but also just like it's got to be digestible.
Yeah. And then on the kind of third-party AI implementation piece side of things, it's been interesting to work with. So, you have vendors out there that have tools, and the way that we have gone about implementing these is starting with a pilot. That's kind of been the way to go. That's proven useful, is starting with a small subset of the ambient scribe. Small group of providers that are going to try it out. Just from a cost standpoint, just making sure this is a tool that's going to be useful. Let's generate some ROI metrics on it, and then also start to understand what are the technical pieces that you're going to have to go through to get this implemented for all 2,000, 15,000 people that could use this.
That's like, got to contact IT and like get the resources.
It's you got to have all those stakeholders in those early meetings of the clinical side, the IT side, funding pieces. Figure out all of that before you hit go.
Yeah, that sounds like a lot.
Yeah,
a lot of ducks to get in a row.
Absolutely. And so there's a lot of kind of just high level stuff, but a lot of nitty gritty of like, how do we assign a license to a person and do that at scale? Yeah. And then, if someone's having an issue, how are we getting that feedback? Are we working with the vendor to get that? Are we getting that data directly? Those types of things.
Gotcha. Well, because one thing that I've noticed as I've been playing with AI more is that the Google Suite seems to be much more personal, as opposed to like Copilot. Microsoft seems much more kind of work oriented. Because when you were talking about the Scribe AI stuff, immediately I think Google Meets has that capability baked into it, where it'll just I mean, I guess there's a missing piece from the Scribe, because it'll just record everything that you say, and then you've got that document. Right. It doesn't have the Scribe piece where it's like you record everything and then transcribe it into like.
And here's clinically what's relevant.
Okay, and then it's like the interpretation
third level
piece.
Of that.
Okay, I'm seeing how that is really powerful.
Another vendor that we're working with for AI related stuff is for clinical decision support. So doing research within a patient encounter, say, I got one example of a patient asking their cardiologist if they started taking ashwagandha, would it affect some of the other stuff they're taking? And he's like, I don't know. So he went to the tool and said, what are the effects of ashwagandha on someone with this case? What it does is it uses a RAG method to look at a huge corpus of research papers, textbooks, and some manually curated clinical information systems. And so it pulls out the information, shows you where it came from, and summarizes all of that within a few seconds. And so
that's very cool.
Yeah.
It's kind of, I've noticed the Google product Notebook LM does something similar.
Yeah. You just don't have to select the sources. It has that sources behind it.
Yeah. Which that's this.
And really the value is the corpus of research. It's just making it accessible.
Right. Because we're almost in an age where there's too much information. I guess we are in that age.
Yeah.
Where it's like, it's almost more important or salient to know what to cut out.
in healthcare, I think they say that the amount of clinical research doubles like every 6 months.
Double. Wow.
Yeah. And so for these providers to stay on top of like what's the latest, way of doing
That
things,
sounds like
it's a near impossible
task. That's wild. All right. This has been a great conversation. Let's close out on this topic. So before we hit record on the podcast, you were talking about how you don't think AI is going to completely, like we were talking about the Anthropic CEO saying in the next year, 50% of entry-level white-collar jobs are going to be wiped out. Your kind of read on that situation is that's just kind of BS, PR stuff. Like, where do you think AI is going to bump into or affect?
I think the timelines are off.
Okay.
I will also.
So because of the implementation piece that we talked about earlier.
That's part of it. I think that's a big part of it. The other piece that I will preface this answer with is that I do try to ground myself in the things that we can do now, and the forward thinking I try to stay in touch with. But I think it's also
just a guess at the end of the day, right?
It's a guess, but you can get yourself in kind of a time warp there where that it can kind of be soul sucking and all consuming to think about. I think that I think my timelines, even from kind of when the ChatGPT revolution started, have extended some. I think there are a lot of jobs and roles that will be automated. What comes of that? I'm a little more hopeful that it leads to higher order thinking.
Yeah.
But that the thing that takes the longest is fixing broken systems, and
so AI
just patching. Patching broken systems makes a slightly better broken system.
Well, it's interesting because the first guest we had on was Joey Cheek, and he was saying that AI is going to affect those people kind of down the value chain. Like, it's not going to affect the doctor, probably won't affect the nurse, but that scribe.
That's going to change too, though, eventually.
Yeah. Well, this is kind of near, which I feel like near short term has changed within the past like 5 years.
Yeah.
So do you think the scribe profession is going to be pretty much wiped out at this point?
Yes, there's going to be people that prefer it, but yeah, that one's going to be gone.
I think that's what the Anthropic CEO is talking about, is like, although there is a counterpoint to the entry level or junior level jobs, like you need a pipeline to develop talent to move into, intermediate and advanced jobs. So like, I don't know, maybe that just changes the relationship of employment, where the entry level people, it's like, we got to take a hit on this. We could have probably saved money going with AI, but we're not maximizing for the near short. Well, I mean, I guess that's a pitfall of capitalism.
I'm going to say that's never happening. But I think that, there's going to be plenty of opportunity to shift to higher order things, even for people that are still learning. But yeah, again, with the scribe, though, that was a model that was built to specifically take that job.
But I think thank you for bringing that. Like, we didn't rehearse this. I didn't know you were bringing up that example before. That is such a good concrete example for me to kind of sink my teeth into, and like, from your perspective in industry, like, what does that look like?
Yeah.
Because I mean, I don't know. If you're a scribe and you're listening to this, no offense, it doesn't seem like a great job that pays very, like, do you know how much it pays? Like,
I don't imagine it's super high paying. And like I said, a lot of people, there are people who've done it full time as their job, but a lot of people also do it, as they want to be.
It's like a summer job, yeah.
But maybe with a little more experience. But yeah, kind of one of those first step jobs for a lot of people.
Gotcha. Well, Luke, this has been awesome. I feel like I learned so much just from sitting down and talking to you about this. Excited about the meetup. Thank you so much for coming on.
Absolutely. Yeah, excited for that.